Hello and a very warm welcome to this King's Fund online event sponsored by Radar Software. We're going to be discussing ways to improve continuity of care for people as they move through different parts of the health and care system, and we'll be focusing on the role that data can play in supporting improvements in people's outcomes and experiences of care across different settings. I'm Anna Charles, the Senior Policy Advisor to the Chief Executive here at the Fund, and I have a particular interest in integrated care, so I'm really looking forward to our discussion today, particularly as we have three great speakers: Simon Williams, Director of Adult Social Care at the Local Government Association; Paul Johnson, Co-founder and Chief Executive at Radar Software; and Liz Sargeant, Clinical Lead for Integration of Health and Social Care in the NHS Improvement Emergency Care Intensive Support Team. Now, before we go into our discussion, I'll just give a brief outline of how the event will work. So this is a pre-recorded event, and ahead of the recording, we've been through the questions that you, the audience, sent in when you registered. So we'll be answering as many of those questions as possible throughout the discussion today. But we'd also like to invite you to submit more questions via Slido during the event, and you should be able to see a box next to the video where you can submit those questions. After the event, our panel, myself and our King's Fund Library team will then look at those questions and we'll post answers to as many of them as possible on our website after the event. And we'll also be putting up some poll questions for you to answer throughout the event today. So those questions will pop up at various points during the session. So look out for those in the box on the right-hand side of your screen and do take part in those. And we'd also like to encourage you to follow and contribute to the discussion around the event on Twitter using the hashtag KFOnline. And finally, you can also find some useful resources and reading related to the conversation that we'll be having today under the resource tab, which again is on the right-hand side of the video. But I think that's enough from me as an introduction. So I'd like to invite our speakers to introduce themselves now. So Simon, perhaps I can start with you. Could you tell us a little bit about you and your role?
Sure. So I've been doing this role in the Local Government Association for 3 years. And essentially, it's around trying to work with social care and local systems to improve outcomes for local people. And some of the job, and quite a lot of it at the moment, is also advising central government on things. Prior to that, I was a DAS and Director of Housing for 11 years in London. And actually, scarily, I've been doing various jobs about integration since 1988, which is quite scary, isn't it? And there's quite a lot of thoughts about what's worked and what hasn't worked.
Great, thank you. Paul, perhaps I could come to you next.
Sure. Paul Johnson, so CEO at Radar Software. I've been in the kind of technology software systems game for about 20 years now, and then in the last kind of 8-9 years, purely focused within the healthcare. I suppose our role and what I hope to bring up to the conversation is the part that technology and data plays in underpinning these complex processes and sometimes simple processes across the healthcare front.
Hi, I'm Liz Sargeant. I'm a physiotherapist by background, and I also have worked in integration for a very long time. I was a paediatric physio, so had to work with education and social care for the first 20 years of my career. And then since 1990 have been working with various great colleagues in social care, looking at ways we can make services better, increasingly for adults rather than children, from my perspective, over the last 29 years, it must be now. So I work for the the Emergency Care Improvement Support Team, and clearly for the last 8 years, I've been focused on the interface between hospitals and out of hospital, looking at ways to help both the flow through the hospital, but most importantly, outcomes for people leaving hospital to be able to go back to their own homes wherever possible.
So over the last few months then, as the health and care system has been responding to the COVID-19 pandemic, it's been, I think, more important than ever to make sure that people have smooth transitions of care and people are receiving the right care in the right place at the right time. So I'd like to come to each of you, if I may, to hear some of your insights into what that's looked like over the last few months. Liz, I wonder if you could start us off. You talked about the join up between hospitals and the community. So how has that evolved over the course of the COVID-19 pandemic?
It evolved very fast. So I think things started to hot up in March. I was actually not in the country, and as I arrived back in the country, I was rung up by somebody in NHS England to talk about how can we get a discharge to assess model in place tomorrow almost. I think we wrote a document in 9 days, which was a new policy on discharge. We didn't write it as well as we might have with partners, but basically that has taken away the friction at the point of discharge between health and social care. And so during the COVID pandemic, nobody has been charged for anything, and that care has remained in place free of charge up until now. That is about to change slightly in that the funding will only last for up to 6 weeks, but we've secured funding from Treasury to continue that approach so that people are not assessed for their long-term care needs when in hospital. And I don't think we've got it right yet, but I do think it's getting better than it was. And we've certainly freed up a lot of hospital beds. There's a fair amount of evaluation still to go on to check whether the outcomes have been good and what the impact has been, particularly on older people. But it was based on a home first approach, not a discharge to any other bed. And it has allowed us to really begin to look at demand and capacity in communities to understand what will be needed to achieve that discharge to home if you came in from home.
And that's the discharging people from hospital side of things. What about when people need to be admitted? Have there been changes there too?
They have. So the same money is available to be used for urgent community response, the 2-hour response, to prevent people even getting in an ambulance or a car, and also to turn people around in the emergency department with our social care colleagues to get people back home if they really didn't need to come into an acute hospital for an acute medical need. And I guess the other bit we've altered within the hospital is actually a set of criteria for clinicians to use to look at whether somebody truly needs to be in hospital or not. I think it's early days with what are called the criteria to reside, but that will also help because it means the variation in length of stay related in effect to some areas of clinical practice will also hopefully be reduced. And we know if people stay in hospital less time, they need less care on discharge. So it's a win-win all round.
Really...
I'll be interested in Simon's view.
Simon.
Sure. So although that guidance that Liz talks about was developed quickly, we welcomed the 2 key tenets, which is that people should have their ongoing needs assessed outside hospital wherever possible, and that people should get the chance to go home wherever possible, home first. And those are both things we've been supporting for years. And I think what we saw was a kind of very rapid take-up of that, and we were pleased with that. And in a lot of places, it's worked incredibly well. Inevitably, we've kind of noticed that generally systems where there are already good working relationships, as ever, made new policies and guidance work well, and there were probably more struggles where the relationships weren't always in place. Probably the other couple of things I'd talk about was about equality of esteem for social care, that what we've really learned through this is the need for social care, including social care providers, to be treated as equal partners in this endeavour, getting the best outcomes for people. And we've learned some lessons the hard way, haven't we? But a lot of kind of really good things have gone on, and I think a much better understanding about that. And I think the last thing I'd say is I think it's quite informed by user experience. So what we've also seen is that people have had some of their traditional forms of support stripped away. because we've had to close day centres or because people were frightened to go to A&E. And inevitably, you can sometimes find some positives from that, as people have shown themselves to be resilient and imaginative, but also some quite worrying sort of issues for us to pick up about sort of people's lived experience through this. And we've been working particularly with, I think, Local Act Personal and some other organisations like Health Watch to really understand the impact on people. And as I say, to kind of try and distill what might have been positive and has worked quite well, and some of the things we need to be a bit more worried about as we look ahead.
And of course, some of the community support I suppose people rely on so much when transitioning from hospital to home or enabling them to stay. Yeah. It's often run by the voluntary and community sector, and we know there's been a big impact over this period on voluntary and community sector organisations. I mean, Paul, as a technology supplier, you must have quite a different perspective on what's been taking place over these few months. I wonder if you could say a few words on what that's looked like from your side.
Sure. I think when the pandemic first came out, I suppose that there was an element of paralysis within these organisations. I think the thing that came across first and foremost was this demand for visibility and the ability to communicate. And so what we saw from our existing customers is this demand to quickly apply technology and data to help them manage their way through that pandemic. So if we bear in mind that policies and process and SOPs are all in place, and if we just take the care home setting as a starting point, significant challenges and demands that were put upon them, and ultimately we have to now operate in a completely different way. So I think again that just highlights the need for having kind of systems and the data to help you make those informed decisions. So we saw a huge demand across that in terms of quickly creating COVID-related events, infection control processes, and simple things whereby what do we do if somebody has been symptomatic, and how do we respond to that? So applying the system to deal with those. And then what we found as well is, and very relevant to this topic, is that some of our customers actually do provide intermediate care services. And so transition those patients from hospital into their settings and then taking them for all their step down care, their rehabilitation. With COVID-19 having now additional checks and balances that needed to be in there, and in one instance we underpin the complete process from a hospital right through to the setting, because you have to have those data checkpoints to make sure that you're assuring the service of where the patient is coming from, and also that you're assured that from a hospital perspective that it's safe to do so as well. So I think without systems and data, we saw requests for information from us increase, and then across our customers applying the technology to deliver against those challenging demands.
So Paul, that was really interesting to hear that perspective, and I wonder, Liz or Simon, whether either of you have any examples that you've come across of how data has been used over this period to support transitions of care or join up different bits of the system.
I might give a couple. I wouldn't say they only started during this COVID period, because I think there was already work going on where they were kind of seeking to do it. But an example would be Nottinghamshire County Council working with Sherwood Hospitals Foundation Trust, I think they're called, where they have a digitised discharge to assess kind of platform to actually kind of draw together all the kind of roles and structures and processes into a single platform that people can kind of really, really easily kind of access. Or a bit of been hearing about some work in Rotherham, where they have a kind of Rotherham health record where they're looking to kind of join that up with the social care record that's being used. But I think alongside what Paul has said, I'd also say that maybe the biggest single change is not, obviously if there have been new systems put in place, that's great. But I think there's been a lot more flexibility and determination just to use the systems we've already got better, and a greater preparedness to share information, and not getting quite so hung up, I think, about some of the all the kind of rules and regs about it, because I think we realised there was an overarching imperative to make things work. So alongside lots of where people have used quite kind of ordinary technology, for example, to do visual consultations for residents of care homes, to enable clinicians to kind of give a good oversight to residents there. Things we've been talking about often for years that we've managed to kind of actually put into place. And that's not so much about new technology, it's more about saying, on a balance of risks and benefits, this is absolutely the right thing to do at the moment.
Liz,
So,
anything?
I think really to build on what Simon said, I think for me, this wasn't necessarily about new during COVID. The systems that were already beginning to use their data more intelligently together have, I think, fast forwarded that. The virtual consultation issue is massive in terms of community capacity. We've seen district nursing caseloads or community nurse caseloads go from 25 per nurse up to well over 100, where they're using a virtual consultation approach, reducing footfall, all of which will help us with continuing what we've done during COVID, where many community services were reprioritised. I think we've seen many ways to make more effective use of the workforce, which then I guess takes me to what I think is one of the bigger issues we've got with data, which is the paucity of community services data. We have very little. What we have is in the community services data set, which is variably responded. So it's really difficult to do any comparison. We know that many local systems, a bit like with local authorities, have got better data at a local level. And I think we need to be better at saying what we think it would be helpful for local systems to be able to do, but not necessarily report it nationally and aggregate it to a point where it doesn't really tell us what local systems need to know. So I think we've got a responsibility nationally to help with helping systems work out what is useful to collect. The other interesting reflection is, with the loss of the delayed transfer of care information, some systems saw that as a real positive and began to look at what was the capacity they needed to do the home first. And other places really wanted to hang on to counting delayed transfers of care still, because it was all they'd ever had and all they'd ever known. And I think we've seen quite black and whitely a very different way of approaching the opportunity the loss of detox has given versus what's seen as a loss by others. So yeah, I think data is, it isn't actually, for me, it's not about data, it's how we turn that data into usable information, which needs some operational addition to it. Sorry, analysts, rather than analysts just looking at it, numbers can tell you something, but we don't know what unless we contextualize them. But it does begin to move us from anecdote to real information, which I think is vital. Simon now wants to say something.
Is that right, Anna? I don't have a fancy electronic way of asking to come in. I'm just going to make one other quick point, building on what Paul and Liz have been saying about another example of using data. We were already doing it, but it's proved even more important during COVID, whereas part of our support offer, we've gone into some places and looked particularly at the kind of reablement intermediate care function, and the whole issue about how you right size capacity from hospital through reablement and intermediate care into ongoing home care. And examples that you don't have to always put in new systems. It's about just using the data that we've got in our existing systems and asking the right questions about it can give some enormous benefits.
And I want to just return to the sort of the picture that Liz painted of, I guess, quite sort of patchy information that can currently be available? If you look across the system, you might be able to say a lot about what's happening in hospital and hospital capacity, and much less about community services and also general practice and social care. So I wonder if any of you have any examples of whole local systems where they've started to sort of address that problem about the quality and visibility of data across the whole system.
I'm happy to kind of comment. I think, in actual fact, if you take some of the larger groups, and the example I would give are the large GP federations, and so what you have there is you have lots of GP practices dispersed over a large geographical area, but they're being centrally managed from one point. And then feeding into those GP practice, you then have social care, you have patients and outreach services. I think what we've seen there is that they have taken almost this integrated care system approach, which is how do you feed in all the data points from all those remote services, the GP practices, to start informing one picture and how the organisation responds to that. And I think the thing that we're seeing as well is, in actual fact, you can enable any location, regardless of their sophistication from a technology perspective. This isn't just about everybody needs to have a fancy piece of software and high levels of technology and capability. Ultimately, so long as people have access to the internet, they can be integrated into the system. And that's what we're seeing from some of our larger GP federations, some of the larger groups as well. So some of those large brands that, again, multiple service types, community services, primary, secondary care, they're integrating all of those because you can quickly enable people through the platform to then engage accordingly.
And Liz, you're going to come.
So I think we've got a number of systems doing that, using all sorts of different systems to do it. And I agree around the ICS. However, sometimes the population-based, place-based approach is also really important. So it goes back to what's sensible to aggregate up and what's sensible to know at a very local level. And there's no one answer for all. In terms of IG, I agree with Simon, because I think people have used COVID not to inappropriately use patient information, but we've got examples of hospitals, primary care, community care, and ambulance services that can now all see the same data about a person, significantly reducing the risk of them being taken to hospital when indeed they've said that's what they don't want. So I think as we move to more anticipatory care planning and people having stated what they want to happen in various circumstances, it's going to be more vital than ever that we use joined up information. Otherwise, what's the point in an anticipatory care plan? But I'm interested in Paul's view. Population health seems to me like something we've been striving to do for a while. And we always look at the reactive end of the data we've got rather than how we can understand and stop it in the first place.
Yeah, no. I mean, I completely agree, and I think when we talk about this data-driven healthcare and data-driven approach, it sometimes confuses. In actual fact, I would prefer to call it informed healthcare. And what I mean by that is, if you take, let's use a very simple example of an ICS model that we were describing there. Ultimately, because you can switch on and enable all social care providers, we can start to monitor, care home by care home, different social care providers, and using a really simplistic thing such as tissue viability, pressure ulcers, or something like that, that ultimately, as these things start to escalate, could result in an admission into hospital. What we mean by this data-driven approach, or this making informed healthcare, is because the systems are intelligent enough now, we can be monitoring at specific locations that they are maybe not performing at the same level of others in terms of tissue viability, wound management. Now, because that is being monitored in real time, you can trigger interventions. So we could inform the community nurses that there's a training initiative to be done at that location, but also interventions to address the issue itself. And then when you look at medication errors, safeguarding events, whatever it might be, because you can feed them into, you know, a central system, you can then write the rule sets as to how do we want to respond and intervene, rather than it become, as you say, this reactive element at the end of it where we analyse. Actually, let's create the rule sets and inform the system as how you want it to respond when you see these deviations, when you see these peaks and rises. This is absolutely off-the-shelf, demonstrable capability that exists, and we need to join up all parties to make that happen.
So we're really talking about data not for data's sake, but as usable information that staff and others working across the health and care system can draw on to inform their practice. And I suppose the things I'm hearing from you about are the things that requires for it to be real time, for it to be visible across the system, and for it to be in a form that people can process and use as and when they need it. I mean, one thing that I think is interesting to consider is whether the needs of health organisations and social care organisations are the same in this regard. Simon, you might have some thoughts on what, if any, differences there might be in terms of the needs.
So I think, I guess ultimately we use information to record what we're doing for our customers and to make sure we can then aggregate that in some way to get better outcomes. Probably the difference is that the NHS has a far more sophisticated and more centralised system, and what we have in social care is more fragmented. And so that's probably one of the learning points for us during this crisis, was that it's at the end of the day, it's 150 local authorities have a statutory duty to kind of hold all this together, but it is helpful for us to be able to aggregate that up, and that's why we now know much more about sort of providers than we ever did before, because of a couple of data collections that we've set in place during the crisis. They're not perfect, but they've given us a much greater kind of insight into what's going on. So I guess our needs different? I'm not sure our needs are different, but I think the kind of mechanism is, as I say, much more kind of locally driven, and that has some good things, but some things we can kind of learn about as well. And I'd probably like to particularly reflect on the bit about social care providers, because I think they've often been a bit overlooked when we talked about whole systems, partnerships, and kind of shared intelligence. And I think they're much more visible now as a result of this crisis, and some of that for bad reasons, some of that for good reasons. And we need to really kind of capitalise on this now. And as Paul says, there are already some really good examples, I think, in places like Lincolnshire or County Durham, where the technology is going into care homes to give that kind of real-time sort of vital signs, clinical information for people living there, that's going to enable all of us to give much better support. And I think the last point I'd probably make is, I think we might use the word shared intelligence more than shared data, as we would say data takes you so far, and it's great to have it, but actually there's a lot of soft intelligence that we all use from our frontline practitioners or from the providers that we work with, that we also need to kind of draw together to give us that full picture. So even if the data isn't perfect, there's still a lot we can do on a shared intelligence basis.
And I think one of the bits, and Paul just mentioned it, was it's the monitoring and enabling us to benchmark and see when things are varying to what you would think the normal should be. And that can be in the moment for things like pressure sores in a care home, but more importantly, the variation in length of stay, clinical practice, the outcomes for people after reablement, etc., are all areas where I think we need to be able to see better, because we have a limited resource, even though we've had some extra money short term. In terms of people, we will struggle with qualified staff. and we've got to make the best use of those. And if one system can get 100 patients on a caseload versus 25, I don't think that's acceptable long term. And so it shouldn't be used in a performance kind of way, but how do we use benchmarking data to encourage people to want to deliver the best service they possibly can? And I think we need to take some learning on how to use data for improvement rather than data for performance management.
That's an interesting point about how the data is used and for what purpose it is collected. Paul, I don't know if you have anything to add to that.
I think, they're great points that are being made. I mean, I think if you think about systems now in the way that we look at KPIs and datas, the technology is there now and the sophistication that we can start to determine as to what are the rule sets that we want to set against those data points, so that we can genuinely drive quality improvements across healthcare. And so, gone are the days of just looking at reports and then reflecting on them. We can start to say, if I see a deviation more than this, if I start to see a spike, I want this intervention. But ultimately, we can track back now from, and Liz made a point around, the length of stay and referrals back into hospital. Because the data is there, it can support that full root cause analysis, and we can track back as to what were the reasons that are driving, extended stay, high referral rates back from rehabilitation instead of discharge home. We can feed those into, this informed care and making those decisions. So, I mean, I know it's a topic of this conversation, but, data and having it in real time and making proper use of it is absolutely paramount for us moving forward.
So we had some questions through from the audience ahead of this discussion, asking, I think, more broadly, actually, about what the barriers are that really stop integration happening. So it's quite a big question, but particularly asking about the barriers between health and social care. Some of our audience members shared their thoughts on what those barriers might be, ranging from cultural issues to information governance, all sorts of things. So I wondered if you could share your thoughts on the different barriers that do exist. And also questions from our audience were about, well, how can we draw on evidence-based solutions to those barriers if we know what they are?
So I think one barrier is this, how you match up kind of centrally driven structure within the NHS and quite legitimate targets that a national organisation would have with a kind of local system, and in where it works well, there is mutual respect and appreciation of each other's kind of bottom lines and must-dos, and there is kind of honesty about things like budget savings that have got to be found next year. And in systems where it doesn't work so well, people skirt around some of those things, or are almost continually surprised that each side have to find savings, or we have performance bottom lines to make. So to me, you could call it a barrier, or just being kind of really, really upfront about that. I think secondly, there's quite a lot of, in terms of good outcomes from integration, some of the evidence that we have is kind of approaches to risk, and what we would call an asset-based approach can be a tension that we like to think in social care, but not always. We try and sort of let people be as independent as they can. The evidence is that for people, particularly working in hospital settings, that can be harder to kind of forecast, and people therefore leave hospital with more service than is actually good for them and that they need, and that's actually disabling. So that kind of differential approach to risk or independence or people's ability to run their own lives is an issue. I would say thirdly, an obsession with structures. I used to say as a DAS, well, my job is to get something working at the front line that can't be undone next time there's going to be a restructure. usually in the NHS, but not can be equally well be in local authorities, that we continually obsess with tinkering around with structures at the top, and they can be kind of worthy of themselves, but somehow you don't get round to actually joining up the service for the end user and working with frontline practitioners in those teams, be it in the community or hospital. So my own view is you should start at the front line and make that work. And then if you need to do something structural, then do it. But only if you need to, and don't get too obsessed with it. And then probably the last point comes back to culture and leadership. And culture is kind of lots of things, isn't it? But where things seem to work well is where the systems listen to each other, have a high degree of trust in each other, own each other's problems, and listen very, very hard to the voice of the end user and of the frontline practitioner or clinician. So it sounds a bit soft, doesn't it? I'm a social worker, so I probably would talk about relationships, but actually there seems to be a lot of evidence that the presence of that, of the absence of that, makes a tremendous difference. And it's those things which would be a barrier or a driver, much more than some of the more technical things that we like to think about.
And actually, you say it sounds soft, but I think what we know from experience and evidence is actually that some of the hardest stuff is the relational work, is some of the most difficult.
Yeah.
Liz, anything to add from your perspective?
Not a lot. I think we've worked together for too long, and I've gone to the dark side from health because I have much more of a social care view of the world. But I think trust is absolutely key. We've mostly seen those systems that were already had a lot of trust make the most of the reduction in the friction at the interface. But there have been a couple of places where the relationships weren't great in February, where actually they've delivered spectacularly, if I'm honest, and are now saying they never want to go back. And I think if people really took the sad opportunity that COVID gave them to focus on the people, and they never had to look at a total population quite so much, because they had no idea what was going to come in and overrun the acute trusts. I think that changed some behaviours in the NHS to listen and work with their partners differently. And I think it's about how we move to a more collaborative style of leadership. And oddly, we're talking about data, but I think using data as intelligence to help get you all on one page is really important, because you all have your own view of the world. At the end of the day, whichever system you're in, there's only so many pounds across the whole system. So they will make the best of it if they do that. So I think focusing on the outcomes for the population and the people within it, having a leadership that is on one page about that, which frees up the frontline staff to act. That was what we heard from frontline staff. We've had permission to act during COVID. And so it is this balance between, because there was central control during COVID, but it was about big things. And they left the small things to be developed at a local level, because that was the only way it was going to work. And I think that's helped leaders at a local level build relationships, not everywhere, but in many places better, as Simon says, in that slight friction between local versus central. But all the other things around risk aversion, obsession with structures, this is complex adaptive change. It's organic and it cannot be managed in a mechanical way. And the places that are still having meetings about how to implement discharge to assess are the places that haven't ever delivered it, because they started with a meeting instead of going, oh, all the rules have gone, let's actually just try doing, we've got money, we've got a person that needs to go home, how can we do it? Yes. And to the frontline staff's ideas about how that could be achieved. And now we've got a real challenge on our hands to try and spread that learning elsewhere, for which data will be vital. But another feature of the systems that aren't working so well is they've done less on the data front as well. So I'm interested in how we help people who are still stuck because they're not doing it deliberately, and there'll be a reason, and there'll be a lot of culture that's historic. So yeah, I don't know if that's really answered the questions. Glue roles in these systems definitely help, and Simon and I have discussed these somewhat, where maybe all the chief execs are too busy with their own pieces still, but if they invest trust in a single person to work for them to help manage some of these interface problems, I think that's probably the biggest thing we can do to help. But they will need to have data. They can't sit in somewhere and do that without something to help them direct traffic.
Paul, did you want to reflect on any of what you've just heard from Simon or from Liz?
Yeah, sure. I suppose from this, maybe a personal view as well, is that I think we still have this siloed working. So social care is still to some degree in its own silo. The NHS is in its own silo, local authority, and then central government. And I think we saw that, and it was easy to criticize, and it became a little bit political, but people were identifying the disconnect between those component parts. And then just picking up on some of the comments there, that, this inability of awareness of what good looks like, and going away to try and just apply some money and try and solve a problem that quite often have been solved elsewhere. And then directly working with, probably more so with our NHS, or in the NHS world, if you like, is that there seems to be this, when you talk about barriers, if I have been saying that I think we should do X, I think we should do Y, and I say this over a period of time and I'm never listened to, and I might be a frontline nurse, or somebody, operating in the hospital, not in a senior level. And then over time, I just find, well, there's no point me raising this because it's not going to get listened to. So as Liz was alluding to there, that having that ability to hear those people, understand what is possible, and maybe even having, as she alluded to there, somebody responsible within the hospital to be accountable for these changes. Because people, after a period of time, say, I'm not going to raise this anymore, even though I've got the greatest idea, because it doesn't get acted upon. So I think it's a barrier internally that we need to fix as well.
So I want to just pick up a bit more detail on the points that have come up that I think particularly Liz, you made, about what's happened in the last few months around reduction in the friction at the interfaces and how people have been able to capitalise on that, and also people being able to capitalise on a kind of permission to just get on and do stuff. And I wonder how sustainable do you think that is in terms of something that we can capture and make the most of going forward, or does that depend on the very unique set of circumstances and changes that were made over the last few months, and therefore things will go back to how they were?
So there is every intention to continue those changes. I think in Simon Stevens' letter 2 weeks ago, he announced the money from Treasury short term to do that, and that's still being discussed ongoingly. Interestingly, some systems have done it and are saying, actually, because we've found more effective ways of working, we've cross-skilled staff, we've reduced footfall, we're doing more virtually, we're not actually sure we need that much more money to do this. Now, one of the dangers of that is we've got very little benchmarking information on the amount of money spent by health or social care in the out-of-hospital sector. So we don't know whether we're comparing apples with pears in terms of are they able to say that because they had more investment in the first place? And I have no idea, because that data doesn't exist. We have now got the data of what each system has claimed during COVID and will continue to claim for the following 6 months. And we'll begin to look at that and try and get underneath why there is such variation. Because to be quite honest, it won't be about the new investment. If you look at the amount of money currently spent on all these short-term services, intermediate care at home, intermediate care in beds, reablement in beds, reablement at home, end-of-life care, because this pathway covers everybody. There are no criteria, which is one of the things that has helped. there are millions already invested in these services. Whether they're invested in the best way possible is going to be the challenge to understand. And I think that will link to, and I hate to say the word, but almost the productivity we're getting from investments currently. And that's where the lack of community data is a hole, and social care data to an extent. I think social care has probably got more of an eye on it than we have on community services, but that's not nationally available data, it's local.
Simon.
What I say is, I very much agree with Liz that working properly in this integrated way is not only sustainable, but can actually lead to some overall savings for local systems. And we've kind of seen that anecdotally in the way Liz says during the COVID emergency. But the work that the LGA sponsored also gives further evidence for that. Some work we did with Newton Europe in 2015, 2016, which showed, quite significant savings for a local system if we were able to work together in the right way to prevent hospital admissions and discharge in the right way. The key ingredient we need to remember is the level of risk to the provider sector within social care. So when we talk about sustainability, I think the key thing I would want to flag up is that providers have been under significant financial and operational stress. They were already before we went into this crisis, and it's got worse through the crisis. The funding going in has helped, but we kind of need to have that very, very clearly in our line of sight as we look ahead, make sure that we are making sure providers can give of their best. So that's one caveat I would give.
And so, I mean, this discussion of barriers is quite broad ranging. There's obviously a lot of factors at play here. And one of the things we've been discussing through this conversation is the role of data within that. So I'm just interested in your reflections really on to what extent better use of data actually can be part of the solution to this, and in what way?
So I think it's a different kind of data than we've been discussing thus far. We're seeing quite a few systems now trying to develop demand and capacity models so they truly understand what their demand is, so that they can develop the right market to give the right capacity. Because I completely agree with Simon about the volatility of the social care sector. However, we've got a massive opportunity because domiciliary care, which has been quite difficult to recruit to at this time, we're told by UK HCA, is much easier to recruit to. Certainly lower level jobs in the health service, we're getting hundreds of applicants for at the moment, in a way we didn't pre-COVID, because sadly of the way people have lost jobs, I suspect. But we'll never have as big a opportunity to possibly develop the services we need rather than the market we've got. And even care homes who have all their issues, and people don't want to go into care homes as much, so there's a lot of vacancy in care homes currently. If I managed a care home, I'd be looking at how I provided outreach support to people in their own homes, and it's how we support the market with that demand and capacity information to give them some surety to develop new services that actually deliver what we want to commission to deliver the right outcomes. And I think for health, a shift from contracting to outcome-based commissioning is going to be a key feature. So measurement of outcomes, which we're pretty awful at, needs to be something we focus on in terms of data for the future. And by outcomes, I mean the difference it made for the person receiving the service, not outputs.
And that's interesting, and that relates to some questions we had through actually from the audience about the role of strategic commissioning in bringing about improvements in this area, and how that can be done. And I think you're speaking to that, what you've just said.
Accident.
And Paul, what about your views on the extent to which data might be part of the solution, and if so, how?
I mean, it's absolutely paramount. I mean, if we just let's just take the patient journey from hospital to home. I mean, how data would inform that. You know, we have capacity and capability in terms of where these patients are going to go to, which are compounded by the pandemic that we've got at the moment. I think it's also worth noting as well that as we move into this restart phase, and we've had all these people that have had all these deferred treatments, are going to be coming back into hospital, that's going to further compound the kind of bed blocking. So we need to get this right to safely transition people out of hospital that don't need to be there. And then it is, you know, data can inform the capacity and capability of where patients are going to go to. The patient themselves, in terms of their requirements and preferences, again, this is just data that's being captured that feeds into the machine. So now I know what the patient requirements are. I know the capacity of where I can send this patient, the capability that matches those patient preferences and requirements. I need assurance, because we are still in a pandemic, that I'm sending it to somewhere that can assure that. These are all data points. And then the patient journey whilst I'm in my rehabilitation intermediate care location, so I improve that outcome and my experience and hopefully discharged home. Data informs that journey all the way, and when you integrate it all, now we've got holistic oversight, and we can start to expedite safely and ensuring the patient outcomes are achieved across the whole ecosystem. So for me, it's absolutely paramount that we start to hook in each of those component parts.
Simon.
One is there should be a massive opportunity to integrate social care data more with others, because 75% of local authorities use just 2 social care information systems, and we are putting more emphasis on kind of interoperability, and I think there should be some opportunities. The one caution I'd give is I think we're lost if in this search for data we just end up with our practitioners spending more time than they already do inputting data into systems, because there's very clear evidence, isn't there, that outcomes for our end users are better the more time our practitioners have to spend with them. And my slight worry is that in our sort of search for better data, we just load a whole lot more onto our practitioners in terms of kind of recording time and all the rest of it. So I'm all for better data for all the reasons Liz and Paul have given. But I think a test that we should also always be using locally is, and does this actually free up our practitioners and clinicians to give more time to their customers?
So with electronic patient records, the data should fall out of the clinical practice. It shouldn't be a duplicate entry of any description. And just to say, it's interesting hearing Paul talk about intermediate care is not about beds. Intermediate care is primarily at home. And the variation across the country in the numbers of people that go directly home from hospital to those that go via another bed to home is significant, and it's significant by region. So, you know, I just think getting that home first message out there is really important. Most of these people can go home. Only 4% of people aged 65 and over, for 1,000 admissions, only 4% should go through a bedded route to home, and only 1% or less should be going to a permanent placement directly from hospital. And they won't be the older people. They'll be people who've had a life-changing catastrophic incident. So we've also got to not continue to capture what we always have and think it's telling us what we've also always thought. We've got to start challenging. And again, it goes back to benchmarking. I don't think it's right that if you live in one part of the country, you're more likely to be able to remain in your own home than it is in another part of the country. And we need to reduce that lottery that exists across England.
I did just want to come to Paul to ask for his reflections on Simon's point about the staff and user experience of data, because as a supplier, I suppose that's something that you have to think about when you're designing solutions for the organisations you're working with. So how do you go about working with the people that will be using the software to make sure that it works for them?
I mean, there's a great deal of effort is put into that user experience and user engagement with the system. And systems, they measure them things and have metrics in place, such as things like NPS score, which is ultimately how are people using the system. But the key thing to do as well is that we always focus, in the fact that is this system or solution that's been adopted helping them deliver the outcome? Because ultimately it can be the best system in the world, it can be intuitive, I like using the system, but if it doesn't help me achieve the outcome that I need to achieve, then ultimately I will start to lose, faith in the system as in general. And then, there are clever tools now. So we have things such as digital adoption tools, where people, if I've just started with the organization, it's my first day, and I'm now might feel overwhelmed that I've got to use a software platform to record a clinical incident or something. These digital adoption tools are designed that just switch on, and it literally holds people's hands while they use the software, but it has to be intuitive. Otherwise, things like return on engagement as well as return on investment from a system doesn't occur. As soon as you have that in place, people don't want to use the system, people won't report, and then the data itself, just is of no value to the organization. So a huge amount of focus is paid to that element.
So a related point that is also very important is about the involvement of patients and understanding their needs in using data. So I wonder if you could share any reflections on how that can be done. There were questions from our audiences about this, specifically asking for examples of the role of patients in integrating care pathways and improving outcomes. So any thoughts on that?
I mean, again, when we look at if it's from a technology or a data point or whatever it might be, if you look at organizations like the Salford Royal and things like this, where we start to see these digital experience labs, and these are purely focused on ensuring that the patient is engaged and informing their pathways, their journeys. And so and as Liz pointed out in this home first, in order to achieve that, we absolutely have to engage with the patient and extending the system so they are not excluded and have a point in it. So it's feedback, it's the wearable devices, the monitoring that I've got in the home is all feeding in to inform the level of care that I'm having, but it's also feeding into a larger ecosystem so that we can make changes to accommodate more people getting into the home. And those systems are, right from, movement, environmental, as well as taking those personal, stats and things that we're going to feed into their direct level of care. So again, the technology is there. We should absolutely, when we're designing these systems, developing these strategies, keep the patient right at the front of that.
So having done a fair bit of unfortunate mystery shopping during COVID, with a large local organisation that I know has a completely electronic patient record system, I've been really taken by the way they can actually ask me for real-time feedback. I go for a clinic, I will get a text that day asking me to give feedback in a way that isn't constrained by questions. It's soft intelligence they're asking for. Equally, when they're making an appointment for me, oddly, they can actually go, oh, I see you're in the hospital for something else this day, so we'll see you on the same day for the other thing as well, which would never have happened with patient records. So I think you want real-time data for other things, Paul. We need real-time data from the person experiencing the system as well, which isn't about real-time data about my heart or my anything else. It's about how I feel. And I think that soft intelligence, which is as vital for systems as the hard numbers are, is really important and will be the only way we co-design better services with the people who are going to be using them.
And we're coming to the end of our time for this event, but before we finish, I'd just like to come to each of you on the panel, invite you to share briefly one closing thought or reflection on the discussion we've had today. Simon, perhaps I could ask you to start us off.
So I think listening to that, I would probably say three things really quickly is start my advice would be start with the data you've already got in a system, because everyone's got a lot of data. Check out that data against what your frontline clinicians and practitioners are saying. So triangulate the data, that voice from frontline clinicians, and actually what our people using services tell us. Then thirdly, listen to each other, because I've been in so many meetings where it's just data, but it's not a lot of shared intelligence. So really apply ourselves to having a shared understanding of what that means. Seems to me to be the way forward. So I'd be worried if people thought, oh, I can't do anything because data is really complicated. I've got to invest in some huge new system. I think there's a lot can be done with existing systems, and people like Paul can kind of help in how you knit that together into some what I would call shared intelligence for system leaders.
Paul, what would you add?
I suppose the big takeaway for me is, we've got to have better engagement right across, the whole ecosystem. So suppliers, the social care, the NHS, the patient, that patient feedback, as Liz was pointing out, is absolutely critical if we're going to design these systems, make them effective. And then if we are going to have informed healthcare, I'm starting to use that as the new tagline, by the way, instead of data-driven approach. We have to understand as to what is the information that we want and how do we act upon it. So I think, yeah, better engagement and awareness.
And Liz, what about you?
So I think, to build on and not repeat what others have said, which I completely agree with, is data quality is probably one of our biggest challenges. However, I was always taught that you only make the quality better by using it and by feeding back to people what the data appears to be telling us. If they turn around and say, well, that's not true, then the onus is on them to make sure that the data they input is better, because only by having good data quality in will we get good information out.
Well, thank you all. Those are really helpful reflections. We are out of time. I think we could probably keep going for another hour if we could, but I'm going to have to wrap us up. So I'd like to thank all of our speakers from the panel for really interesting discussion, and our sponsors for this event, Radar Software, and of course our audience for watching. So just a reminder that we'll be posting some answers to some of your questions on our website over the coming days. And also do take a look at the extra resources and information in the resources tab at the side of your screen. You can also share the link that you'll be sent after the event with your colleagues and your friends, because they can then watch this recording on demand and you can discuss it with them. And finally, once this video ends, a few short questions will appear at the bottom of your screen, asking you to give us just a small amount of feedback on how you found this. So please do take just a moment to fill those in, because it really helps us to make sure that our next events can be even better. So that's it. Thanks again, everybody, and please do join us again soon for our next online event.